بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Dear viewers, ladies and gentlemen, Dr. Muhammad AlShaya is your host for Elixir of Life, kicking off another inspiring and informative episode with our distinguished guest, aiming to explore new frontiers and bring you the latest information related to health. Our program is filled with many inventive segments. Most importantly, our topic of the week is osteoarthritis of the knee with our distinguished guest, Dr. Osama AlShaya and Mr. Hani Al-Abbad. Without further ado, we'll go for a break. Please stay with us. Once again, welcome back to Elixir of Life. Our next segment will be the quote of the week. Please stay with us. Don't go away. Once again, welcome back to Elixir of Life. Our next segment will be health myth and fact, and we'll talk about frozen and canned fruits and vegetables are less nutritious than fresh ones. To see more details on this report, please stay with us. Once again, welcome back to Elixir of Life. Now we are coming to the most important segment, which is the topic of the week, osteoarthritis of the knee. Osteoarthritis is the most common form of arthritis, affecting millions of people worldwide and Saudi Arabia. It occurs when the protective cartilage on ends of your bones wears down over time. Although osteoarthritis can damage any joint in your body, but the disorder most commonly affects joints in your hands, knees, hips and spine, and will focus about the osteoarthritis of the knee. It's my great pleasure and honor to present my distinguished guest, starting by Dr. Osama AlShaya. He's orthopedic oncology and reconstructive arthroplasty subspecialty consultant from King Fahd Medical City. Welcome, Dr. Osama.
Thank you very much, Dr. Muhammad, and welcome for you and our colleague and the viewers.
Okay, and our second distinguished guest, Mr. Hani Muhammad Al-Abbad, senior physical therapist, master of musculoskeletal and sports physical therapy. Welcome, Mr. Hani.
Thank you for the invitation, and hope we will give good information for the audience.
Excellent. We will start without further ado. Let's go straight ahead, starting by what's the structure or the anatomy of the knee. Looks like a straightforward joint, but I think it's complex. Okay,
I think you're right, Dr. Muhammad. The knee is the most prominent joint in the body. It's made from the distal femur and proximal tibia. It's covered by the cartilage. There is inside the knee there is a meniscus. There is a ligament around it. We can see in this kind of a model.
Excellent. Yes.
This is a kind of, if you can see it, this is a kind of the patella. This is a quadriceps tendon holding the patella up, and there is a patellar tendon holding the patella down. If you can see, this is a kind of a distal femur part, and you can see this is the most blue part. This is a kind of a cartilage, and from inside there is a medial meniscus. It's important for absorbing, acting as a shock absorber, and this is the lateral meniscus, and you can see inside there is anterior cruciate ligament, prevent the knee to slide in the front, and in the back you can see posterior cruciate ligament. In the side you can see a medial collateral ligament, prevent the knee to move side to side, and this is the lateral collateral ligament, and this is where we can say this is a structure of the knee itself. Inside the knee it is filled with the fluid, we call it synovial fluid, and there is a layer of the synovial membrane. It is generated the fluid to make the lubrication and easy movement.
This is the hyaluronic acid that inside the fluid?
Exactly. Synovial fluid or hyaluronic acid. This is a synthetic part of the synovial fluid in case of one of the management we can give it.
So complex joint.
Very complex joint. People, they think it is a kind of a simple joint, but the movement of the knee, you can see it's moving in a flexion extension, little bit pivoting, which is medial and lateral rotation, and anterior drawer, posterior drawer with limitation. And this is why the knee itself is a unique joint in the body.
Excellent. I think in the same line, Mr. Hani, can you elaborate to us or enlighten how does the knee work, the biomechanics of the knee?
Yeah. So from a biomechanical point of view, as Dr. Osama mentioned, that the joint is formed by the distal end of the femur, which is the convex part of the joint. It's a biaxial modified hinge joint. And the second partner of the joint is the proximal end of the tibia, which is the concave part of the joint. The joint has one main functional movement, which is flexion extension in the sagittal plane that dissect the joint into right and left. Within this plane, the joint can move from 0 degree full extension up to, depending on the person flexibility, up to maybe 165 degree of flexion. This movement is accompanied by an accessory motion, intra-articular motion. So with extension, full extension or terminal knee extension, the tibia goes into external rotation, which is important in especially weight-bearing activities and gait with initial contact. And with end of knee flexion, the tibia goes into a little bit of internal rotation. Those accessory movements are of great importance to maintain the alignment from the proximal joint, which is the hip joint, and to transfer the load into the distal joint, which is the foot and ankle, to absorb the forces that we call the ground reaction forces and avoid shear forces that may over time causes degenerative changes.
Excellent. It's great. This leading us, what are the symptoms of osteoarthritis, or is there any classification or types of osteoarthritis?
The osteoarthritis in general, if we talk about it, usually we are meaning the idiopathic non-inflammatory kind of osteoarthritis, which is the common type of osteoarthritis. We see it in our population, especially in the Asian. But there is different kind of osteoarthritis. There is inflammatory kind of arthritis. This is, we see it in people, they have rheumatoid arthritis or a kind of a scleroderma or inflammatory bowel disease that end with arthritis. But if we're talking about the arthritis, which is the classic one, is the non-inflammatory, is the idiopathic, is number one.
Idiopathic mean without clear cause, huh?
Exactly, and usually started, we'll discuss later about the risk factor itself. It can be happening secondary too. We see it in the young population, especially with a motor vehicle accident. A lot of accident happen, damaging the joint, ended with arthritis. We see it with side effect of some medication, example the steroid, long time using the oral steroid with high dose and with avascular necrosis, death of the cartilage and the bone. We see it with post-infection. If there is a kind of infection in the joint and either treated or not treated, there is high chance risk to develop arthritis in the future. The last one is we see it in the malalignment, especially with the bowing of the leg, difficult mechanical weight bearing, ending of accelerated process of arthritis. Usually we see the patient in the clinic or patient complain of pain.
Pain, okay, is the most common. Okay.
This is the most common cause of pain show up in the clinic, either in the family physician or even specialized orthopedic clinic, or even to our colleague in the physiotherapy to treat them from the ongoing symptom. Other symptom we see the patient have a stiffness, which meaning difficulty in term of motion of the knee. We see also a kind of instability. We say that is a kind of a giving way when he's walking, he tried to fall down. This can be secondary to the ligament injury itself, or sometimes it can happening with the sound of a crepitus or knee swelling, or what we call it effusion. This is a classic symptom of osteoarthritis.
Is it a disease of aging, or is it there is a preference for gender, male or female?
You know, everybody have, I will say, a kind of information thinking osteoarthritis is the link to the age process. But recently they found there is totally different between the stiffness and decreased range of motion of the age population versus the osteoarthritis disease itself. The age usually they have a different kind of pathomechanics, stiffness secondary to the laxity decrease in the joint itself and the soft tissue around it, with the high risk of arthritis. But the arthritis itself can happen in the young population, female more than male.
Female more than male.
Female more than 50, very high risk. People have osteoporosis, female high risk also. We see it in the Asian population, especially in the Middle East, more than the European or North American. Also we see it, as we said, with the obese people, overweight, and the people they have a kind of a genetic. Especially if you see osteoarthritis, you will find his father or his mother have arthritis before.
Excellent, thank you, Dr. Osama. We'll go to Mr. Hani. What are the, can you add on what already Dr. Osama mentioned, risk factors of osteoarthritis?
Totally agree with what Dr. Osama mentioned. Generally speaking, people think that it's mainly age-related, and any knee pain may be labeled as osteoarthritis, which is not accurate. We're talking here specifically about radiologically evident osteoarthritic changes in the joint that is manifested by roughness of the hyaline cartilage, toughening of the joint capsule, in addition to these surrounding soft tissues, including ligaments, etc., which will lead as a slow changes over time, manifested by pain, in addition to stiffness. More early in the morning, patients have this as a main symptom. Also, inactivity stiffness. Usually they mention that if I stay in a certain position for a period of time, then I feel like my knee is not flexible. Yes. Yeah. Simple examples are like raising from a chair, here as a local habit, sitting on the floor and standing up from the low surface. Also using stairs, longer standing, and weight-bearing activities. Those are the most common positions, either sitting positions or standing positions, or prolonged activities, walking or running beyond the person physical or fitness capacity may over time result in these symptoms.
Okay, regarding is it more common in obese or ideal body weight?
There is a lot of research that link body weight, body mass index as a risk factor for patients to develop degenerative changes on their knee joints. Other factors, the presence of previous injuries early in their life, either sporting injuries or fractures, accidents, etc. This is a big risk factor. Also, patients with low physical activity level, usually they may exhibit slow muscle atrophy and weakness, and again quadriceps and muscles that control the knee have a big contribution to the development of knee osteoarthritis. Of course, increasing the body weight will put further challenge to the knee joint in weight-bearing activities that will accelerate the load over the joint and ultimately will cause joint narrowing and roughness and the joint to lose its smooth surfaces.
Mr. Hani, is there any kind of sports that increase the risk of osteoarthritis and or decrease the risk? Okay.
Certain sports have been found to result in early osteoarthritic changes. These sports include high impact sports, including long distance runners,
Marathon runners, okay.
yes, football players, sports that involve frequent jumping, sprint and change in speed. So basketball, volleyball as well are one of the high impact sports that put a big demand on the joint that may lead to an earlier degenerative changes among these populations.
Excellent. Thank you, Mr. Hani. Dr. Osama, do you have any figures in Saudi Arabia? How common is osteoarthritis? Is it a common disease? Is it a rare? So if you can enlighten us about this.
I can say the osteoarthritis is the second common disease in orthopedic clinic after the fracture, and in the spine clinic you will say low back pain, but arthritis now we see it more and more, especially with population female more than male, and we also find it that the people of osteoarthritis can reach up to 35% in our population that they have arthritis. This is now, I would say, it is start to be, unfortunately, one of the endemic diseases in our, Asian population, Middle East population, especially with, as Mr. Hani mentioned, is the habit itself, the exercising in a wrong way or sitting in a squatting position, also the genetics itself. We discuss about the stage, or what we call it, the arthritis change in the X-ray, and this is, you can see a kind of a nice model, if everybody see it, that this is a kind of a normal knee, pristine, very shiny, that you can see the hyaline cartilage itself there, and you can see the meniscus, and you can see the hyaline cartilage of the tibia. And with the time start to have, this is what we call the mild stage, stage 1, that you will have loosening of the cartilage, but without much loosening of the thickness of the cartilage or even the synovial fluid. This is the symptom where the patient will have a pain, swelling itself. Then after that we'll go for the next stage, which is the moderate arthritis. You can see start affecting more joint space and more cartilage in the medial and the lateral side, and you'll start to see a new bone forming. This is what we call the osteophyte. It is in the side of the bone. It is a sign of that there is more advanced arthritis. And this is to be honest, this is the classic cases. We see it in our orthopedic clinic, especially in the tertiary hospital, where your patient failed of non-operative. This is where he will reach the no cartilage and only bone with extra bone formation, and he will lose the space between the distal femur and the proximal
This is
tibia.
the advanced stage.
This is the advanced stage, and this is the stage that we should not reach it.
Okay, so what do you advise our dear viewers, okay, about not to reach this stage?
The, the arthritis itself, when it is started, unfortunately, this is a kind of a chronic, which meaning we cannot reverse the arthritis. If there is a kind of a damage in the cartilage itself, either we can decrease the progress of it, or we can make it steady, stable. We try to control the pain itself, and we tell the patient or the population how to do a kind of protective measurement to decrease the progression.
Excellent. So early diagnosis, it can help, okay?
Exactly. We don't want to reach this stage. We want to catch it with the early stage.
Excellent.
The other important thing, try to avoid long standing. What I mean long standing, there is a special kind of a job that you will stand a long time. If you stand a long time, you will put a lot of stress on the joint. Try to sit in between. Second thing, try to use the chair when you sit. Don't sit in a squatting position or sitting in the floor. Protect yourself from junk food. Try to eat healthy, especially the food that have high calcium, vitamin D. Decrease your weight. Also, it is important. And the last important thing, when you take any kind of medication, example the steroid that have effect to cause a necrosis of your joint itself or the bone itself, try to use it with medical control under supervision.
Excellent, Dr. Osama. Now we patient, presented to medical advice and diagnosed to have osteoarthritis by plain X-ray. Now you referred this patient to a physical therapist, Mr. Han. How if we diagnose it in early stage, how we prevent the progression of the disease? Can you just elaborate more? Okay.
Yeah, following on what Dr. Osama mentioned, unfortunately, most of our patients that we see them at advanced stage of the condition, where the management will be more challenging and difficult. But as much as we could help these patients at their earliest stages to prevent further or to slow down the progression of the degenerative changes, this will be of easier job. So it depends on the stage of the degeneration, and also it depends as well on the person or the patient. We in physical therapy don't only look to the disease, we look to the person, and we try to understand their lifestyle in general, and to find out what are their individualized risk factors. We listen to their complaint from a functional and physical point of view rather than from a patho-anatomical point of view. We try to find solutions, strategies to either slow or prevent the progression of the disease, also to improve their symptoms, whether it is pain or a stiffness or functional limitation. So we try to be more of a problem specific, to collaborate with the patients and try to tailor the treatment based on their needs. So as Dr. Osama mentioned, if, for example, the person's main job is standing or requires standing frequently, then we discuss with them other strategies to avoid the risk, including housewives. We see this a lot, even during the normal daily activities. Sometimes forgetfulness or being in a hurry to finish a certain activity and not taking regular breaks, or waiting until they reach or feel the symptoms to take a break or stop the activity. So we listen to the patient, take the full history and identify the risk factors, and then we do a certain or series of physical examinations to assess the joint flexibility and the pain associated with it. Also, we put emphasis on the patient's muscular strength and endurance, That is a big risk factor that we could improve. Also, we add functional assessment depending on the patient restriction. If it is walking or gait, we do a gait analysis, or if it is other activities, weight-bearing activities, or sometimes some patients have a recreational activity restriction, either a recreational sport or activities that they feel now having a problem to do. So that's how we usually approach the patient, depending on their personal. We don't encourage treating patients in general. We try to build our treatment strategy based on their physical impairment and functional demands. And we'll mention later on in the episode the treatment options that we could offer the patients.
Excellent. Mr. Hani, what kind of exercises that can worsen the progression of osteoarthritis, and what kind of exercises that retard or delay the progression of the disease?
Yeah, that's an important question. Exercise in general is promoted for health, but depending on the patient physical fitness and physical capacity, some exercise may be more favorable to be added to their activity. Some patients, especially at an elderly stage, they usually like to be involved or in regular physical activity to prevent chronic diseases like cardiovascular problems, etc. But they usually, with no experience, commit some mistakes. Mainly overdose or overloading themselves, their body, without appropriate warm-up and cooling down, depending on their activities. So generally speaking, high-impact exercises are to be avoided. These includes running, including jumping activities, any sports or activity that requires frequent jumping, or distance walking or running. These to be avoided, and those sports that or activities that requires standing in a prolonged time. In addition, other external factors need to be mentioned to the patient. These includes the surface that they perform their activities, the appropriateness of the surface. In addition, the type of shoe they use is a big risk factor. I see this frequently. Some elderly have the habit of walking on a regular basis, but they're not using the proper walking shoes that acts to absorb the ground reaction forces and prevent excessive forces to reach the joint and causes degenerative changes. So this is something we put emphasis on. We try to investigate the type of shoes the patient is using, the type of surface they are performing their activities on regularly. Also, we see a lot of patients, they don't do a good warm-up in terms of stretching and strengthening exercises and flexibility exercises before and also after the activities, because over time the sport itself or the activity itself may consume or don't give the tissues a period of recovery and restoration of its function. So these measures helps a lot to avoid overuse or repetitive injuries.
So what about, just I will mention a few exercises, what about treadmill? Is it good or bad?
We'll talk about the common assumptions on type of exercise, whether or not it is advantageous or harmful, including treadmill walking.
Because I have asked by many patients about this. So
we too, I get this question a lot, and I did some literature review, and actually we didn't find, according to studies that they compared overground walking and treadmill walking, there was no significant difference on the amount of forces subjected to the knee. If making sure that the type of treadmill is convenient for your weight, of a good quality, and the speed is according to your velocity. Also, no inclination. Some patients use a reclining.
Reclined, okay.
Yeah, this is generally is going to cause shear forces, especially on the patella, the posterior surface of the patella, and cause shear forces.
So it should be flat, okay?
Yeah, better to make it flat and use an appropriate speed. Don't change the speed appropriately.
Okay.
So you will walk within a certain rhythm that you can keep up with.
Excellent, excellent, Mr. Hani. Now coming to Dr. Osama, I think that we are coming to the most important patient. They're asking, what's the treatment? What's the treatment for osteoarthritis after confirming the diagnosis by X-ray or by blood test?
Exactly. The patient doesn't want pain.
Okay.
He wants his native joint, and he doesn't want pain. And we do our best to reach this kind of result, that he doesn't have pain with the same joint itself, which is the native joint, and good range of motion. We started with a kind of modification in his or her lifestyle. We talk about the diet, we talk about decreasing weight. With our colleague in the physiotherapy department, we refer them to do a kind of a strength exercise and to help them in terms of balance, a gait, and a kind of the things that they should not do it in terms of not warming before exercise, not proper shoes putting when they are walking. The other thing we start with, to control the pain itself, we give them a kind of non-narcotic medication, which is medication doesn't cause addiction itself. And the best medication we start to control very simple pain is non-steroidal anti-inflammatory medication to decrease the inflammation. Like we can give ibuprofen, or we can give a medication of COX-2 inhibitor. This is a kind of specific anti-inflammatory medication, can act on the inflammation happening in the joint itself, but less side effect on the stomach. Always we ask the patient about the risk factor, if he had a kind of contraindication to this medication, especially hypertension, previous myocardial infarction, heart attack, or peptic ulcer or gastric ulcer. In this patient, we try to avoid to use non-steroidal anti-inflammatory medication. Always good to tell the patient to use the ice pack over the joint, especially when there is a kind of a fusion or a swelling, because we know if you put the ice, especially you put it in the towels and put it frequently in the joint, it will decrease the inflammation itself. Sometimes he can use the warm back, especially if you have a stiffness without a kind of the swelling. People find it give more laxity in the joint, more flexible. The other medication we can give, if the patient after that he come back to us, he said, I tried this medication, I went with the physiotherapy, they told me to change my lifestyle, doing my exercise, we can stage the arthritis itself. If we are looking for moderate arthritis, sometimes we can replace the lost fluid, lubrication fluid inside, by giving medication. It is synthetic synovial fluid medication. It's called hyaluronic acid, and this injection we can give it for a moderate stage of arthritis, or patient sometime have mild stage of arthritis, he failed the medication kind of management.
I think, Dr. Osama, we will talk more about hyaluronic acid injections, but first let's go for a report about hyaluronic acid and osteoarthritis of the knee. Please see more details in this report. Sure. Stay with us.
Thank you.
Osteoarthritis of the knee is a chronic disease characterized by loss of cartilage, inflammation, joint dysfunction, pain, and disability. Clinical studies show intra-articular injection of HA, which is a primary component of the synovial fluid in healthy joints, can help reduce pain and increase joint function in patients with osteoarthritis. HA is a large polymer composed of repeating disaccharide units. The average HA chain contains 10,000 disaccharide repeats and has a molecular mass between 200,000 and 10 million Daltons. The network of HA that surrounds cells provides a molecular scaffold for many components of the extracellular matrix. HA has unique biomechanical properties. It acts as both a lubricant and a shock absorber within the joint. In addition to its biomechanical properties, HA has many biochemical activities, including regulation of pain, tissue homeostasis, and inflammation. Binding of HA to nerve cells reduces their sensitivity and ability to respond to pain stimuli. HA helps maintain normal joint structure and promotes healing by regulating chondrocyte growth and viability and by stimulating synthesis of articular cartilage components such as collagen, proteoglycans, and HA. The biochemical activities of HA are regulated by HA binding to the CD44 receptor, which is expressed by many cell types, including chondrocytes, synoviocytes, and inflammatory cells. Importantly, the cellular responses to HA binding vary depending on its molecular mass. In osteoarthritis-affected joints, the concentration and molecular weight of HA is reduced as a result of decreased synthesis and increased activity of matrix-degrading enzymes, which occur in response to chronic inflammation. These low molecular weight HA fragments cannot maintain the mechanical integrity of the joint, leading to increased friction, reduced function, and pain. In addition, small HA fragments promote inflammation by stimulating production of inflammatory cytokines and matrix-degrading enzymes. Research suggests that the differently sized HA molecules may affect receptor organization and the ability to activate specific signaling pathways by cells. Longer HA fragments like those found in healthy tissues block receptor activation, whereas shorter HA fragments allow receptors to cluster together and initiate a cellular response. HA suppresses production and activity of matrix-degrading enzymes that cause tissue damage, inhibits inflammatory cytokines that cause swelling and pain, and blocks movement of inflammatory cells that perpetuate the immune response. The unique combination of biomechanical and biochemical properties makes HA an important molecule for maintaining joint health.
Welcome back to Elixir of Life, and our topic of the week is osteoarthritis of the knee, and it's my great pleasure and honor to present Dr. Osama AlShaya, orthopedic consultant, and Mr. Hani Al-Abbad, is a senior physical therapist. Just will go in the same line. We paused and stopped in the intra-articular injection of the joint with hyaluronic acid. Can you talk more about this?
Exactly, and what we find now, especially the awareness of the people start to be increased. People, especially the osteoarthritis people, they come, they discuss about the hyaluronic acid or intraarticular injection of replacing synovial fluid inside the joint itself, and we told them that the evidence itself can help in the mild to moderate arthritis, can help to decrease the pain, increase the flexibility, but
What
It
is
will-
stage the one mild عشان just to okay.
It will help, especially in this kind of two stages,
Stages,
mild to moderate.
Okay.
If the non-operative pain management change the modification of lifestyle not helping. But I want to stress in one thing, that it will not prevent the arthritis of progression. It will not regenerate your cartilage. It will help you to decrease the pain. It will help you to give you more flexibility in the joint. And sometimes you'll be lucky that your symptom will disappear and you will reach a plateau level that no more further progression. We can repeat the injection every 6 months or every 1 year. The side effect of the injection itself, there is no much side effect except the risk of the infection, that it is 1%, but we give it under a special sterile condition with the sterile gloves and sterile the area before we give it. We find around 50 to 60% success rate in terms of controlling the pain, decrease the need of more oral medication of non-steroidal anti-inflammatory medication.
Excellent, Dr. Osama. For you mentioned the frequency every 6 months.
Or up to 1 year.
Up to 1 year. For how long? This can be. Is there any cap that you don't give anymore?
Usually they didn't mention about the how much we should give, but we know if the patient asking it frequently, meaning that there is no much hope, he will be falling within the 40% that there is no effect of it. This is why we will recommend for the patient think about more other alternative management other than the injection itself.
So it is more or less a bridge before knee replacement or surgical option, isn't it?
If the arthritis itself is progressive, but as I said, 60% of the patient, they will have a control of the pain, then the arthritis itself, it will not progress.
Okay, I think we heard about other intra-articular injection to the joint, like steroid injection. What are the, is it effective? Is it can be given for any osteoarthritis, or there is stage?
The intra-articular injection of the steroid, there is a misunderstanding of the patient. Patient thinking that this is a kind of the same steroid that they will take it by oral, cause more side effect, increasing their weight, causing other more side effect. But the intra-articular injection in the knee itself by the steroid usually is staying in the knee, doesn't go anywhere. Especially we should be careful in the diabetic patient, can increase the level of glucose in the first 2 days after the injection. This is why it is important to the patient to monitor his glucose level. We can consider it in a patient that have significant swelling in the knee. He has significant arthritis, which meaning there is a significant loss of the cartilage itself, especially in the elderly population, that we give them the intra-articular injection of the steroid to control the pain and to decrease the inflammation. And it's almost the same success rate of the hyaluronic acid, but usually we keep it with significant pain and significant swelling and more advanced arthritis. This is where we'll consider intra-articular injection of steroid.
Yeah, Dr. Sam, is it contraindicated in infection of the joint? We call it septic arthritis, or because you mentioned the swelling mainly to relieve, so how we have to make sure there is no evidence of infection?
Very important that any patient have a swelling in his knee, not seen before by physician, he should be assessed by physician, because arthritis is the classic cause of the knee swelling. But there is other cause of knee swelling. One of it, as you said, Dr. Muhammad, is infection. Septic arthritis can destroy your cartilage, can cause other infection in your body, can cause osteomyelitis, which is infection of the bone, also the bleeding in the joint. This is why before you will give the intra-articular injection in the knee for the steroid, you should rule out the septic arthritis. You should rule out infection in general in the body.
I think all patients and all of us, we try as much as possible to avoid, surgical option replacement. Is the last resort. Is there any, state-of-art therapy like injection of stem cell in the joint or plasma-rich plasma or plasma?
Sometime we reach with the patient with a state that he need help in terms to control the pain, help him getting more functionality, more movement in the joint. But we fail because either the progression of the disease itself or alternative medication that we try to give is not helping him. Now, in the last, I would say in the last 4 or 5 years, evidence talking about stem cell injection of from the lipid, especially the lipid in the abdomen or in the thigh, they take it and they extract the stem cell and inject it back in the joint. But until now, there is no standard evidence showed that the effect is the perfect. But we don't know in the future what will happen. I hope that with the new future that we'll see more publication, more research about the result itself about the stem cell injection. Also the other one, what we call it the platelet-rich plasma.
So platelet-rich plasma, yes.
Platelet-rich plasma, very simple. They take blood from the patient, then we put it in what we call centrifugation to make a circle movement. After the end of circle movement, a few minutes, it will separate the red blood cell, which is the cell, from the plasma, which is the fluid in the blood. And the plasma itself very rich with the platelet. And the platelet itself, it is important in the clot. Also, it is generated a growth factor. This is why we aspirated the platelet itself after separated from red blood cell, and we injected back in the joint. We hope that the growth plate effect from the platelet will help to at least generate the cartilage that it is lost in the joint itself. There is, as I said, there is no strong evidence yet, but sometime we use it in a young population, especially the athlete, that the joint replacement itself, it will affect his career. At least some kind of bridging, hoping that it will have effect and delay the surgical procedure.
Excellent, Dr. Osama. Are these modalities available in Saudi Arabia, like platelet-rich plasma or the stem cell transplant?
The platelet-rich plasma is available. A lot of centers in our kingdom, they give it to the patient, especially with collaboration with our colleague in the physiotherapy and the sport medicine physician, that they can provide the course of the injection to the patient.
So it's available here?
Yes, stem cell injection, it is in some research centers and research hospital based that can be provided, but we are in Kingdom of Saudi Arabia that we like to see more evidence before we popularize it to our patients.
Excellent, Dr. Sam. Now we are coming to the, let's say, the last resort is the replacement of the joint. Can you talk about replacement of the joint, especially what we call the Islamic knee, which is a new modality?
Yeah, we can see now. This is the stage that will reach of the arthritis. This is the people that usually in the stage we try everything with them, nothing working with them. We assist them medically with the anesthesia and medical physician. Then after that, if they are fitting for surgery, we give them the total knee replacement option. Total knee replacement option have very high success rate. We reach 95% or more with a long survival rate, more than 15 years now. And good result. Patient can go up in the home after 2-3 days from the surgery with a good rehab and physiotherapy.
The joint, okay.
This is a kind of a model. We see it for the total knee replacement. And example here, we can see this is a kind of cobalt chrome, made from cobalt chrome. The arthritis itself, we remove around 1 or 2 centimeter, almost 1 centimeter from the distal femur, and we cap it of the distal femur. This is a kind of total femur replacement. Then in the plastic itself, this is a kind of a plastic in between. This is the replacing the cartilage and the meniscus. Then the last part is, this is what we call it the tibia. It's made also from cobalt chrome metal that will replace the proximal part of the tibia. And this is a small keel of that it will hold intermedullary of the tibia. At the end, you will end with the joint itself, have a nice motion, a movement, and stable, and can stay up to 15 years or more.
Very beautiful. What about the Islamic one? Can you tell me?
We hear a lot of terminology about the Islamic knee, and especially in the last few years. It is a total knee replacement, the same.
The same, okay.
And there is no any kind of a different, more than it give you more flexibility of the knee flexion itself. And they say this is Islamic, which means it can help the patient sometimes braying. We as orthopedic surgeon, we don't recommend to stress the joint, especially to sitting in the squatting position, because the aim of the surgery itself help you flexibility and more walking.
Thank you, Dr. Just quickly, Mr. In brief, what about the important physical therapy after knee replacement? Can you just briefly?
Following knee replacement, arthroplasty or replacement, we like to start with the patient as soon as possible on the first day of surgery. If the patient has no complications, our main goal is early mobilization of the patient, which has so many advantages to avoid thrombosis or other problems. And also to get the patient the confidence that and to overcome their fear of moving the joint. So on the first few days before discharge, we encourage them to sit on the edge of the bed, do some bed exercises. Sometimes we use a device called CPM, or continuous passive movement, especially for those patients who have pain, or still they're not very confident to move their knees themselves. So the device will help them to take the joint within the available range in the first few days. And after that, we encourage them to start walking as soon as possible, which is something that will decrease the complications after all. Of course, walking on the first time requires supervision and assistance depending on the patient's physical capacity. So we provide walking aids according to their condition, either a walking frame most likely. So just to make sure that the patient has no risk of falling, to gradually build up their walking distance.
Thank you, Mr. Hani, and thank you, Dr. Osama, for such informative discussion. Now we'll go for the last segment of our episode, will be health benefit. Please see more details in this report. Once again, welcome back to Elixir of Life. Actually, there was wealth of information about osteoarthritis, the clinical presentation, management, and before I conclude my episode, I wish you have enjoyed viewing our episode and found it useful, and would like to thank our distinguished team headed by our director Abdullah Lulei. And until next episode, I wish you a pleasant week ahead. Assalamu alaikum wa rahmatullahi wa barakatuh.